We've got a good lineup today. We're going to talk about biologics and then a couple of other things kind of spread between shoulder and hip, and hopefully we can kind of bring you up to speed on our current concepts in these topics. So with that, should I hit this or do you want to? Got it. Okay. So let's talk about biologics in sports medicine. My goal in putting this talk together was to give you kind of the update, latest and greatest. Where are we? I tried to make this topic, this talk relevant to what we really know. Level 1, Level 2 studies. There's a lot of static out there, but if you really tease out the randomized controlled trials, there's really not a lot of information we have. So in doing this, I hope that I can kind of give you the summary of where we've been in at least the last couple of years. My disclosures are in the program. So fatty degeneration of tendons, muscles, and articular cartilage is one of our greatest enemies in sports medicine. You look at an MRI like this one, you can see atrophy of the tendon, you can see fatty degeneration of the muscle, and sometimes the solution to this problem is more than just a mechanical one. This particular problem may be unsolvable because there is no biologic stimulus. It likely isn't repairable. We would have to ask this tissue to regenerate in order to solve this problem. Enter biologics, which offers us all of the allure of the Holy Grail. And in studying this topic, what we really want to know is, are we really able to slow down the degeneration of these tissues, and are we bold enough to think that with biologic we can actually stimulate regeneration of these tissues? And these are some of the answers that we hope to answer. So this is our generation solution defined, and we'll be doing that with the use of three of kind of the hot shots in biologics. The first one being mesenchymal stem cells, the other one we'll touch on is platelet-rich plasma, and the third being growth factors or cytokines. And the questions we have to ask ourselves are, what are the best sources of these cells and these agents? What are the appropriate concentrations when we use these for various pathology? And what's the most applicable position for these agents? And no talk on biologics is really complete without at least discussing the FDA and how it regulates these tissues. And what you need to understand is that the FDA basically has an arm called HCTP, which is human cells, tissue, and products. And this is the arm of the FDA that oversees things like allografts. And they also oversee, as you know, drugs and medical devices. And they have two sections by which they oversee this. One is called Section 351. The other is called Section 361. 361 is what they consider low risk, things like allograft tissue. 351 they consider a drug. And those are scrutinized much more carefully, as you can imagine. So what they are constantly looking at is whether we are using these biologic agents as drugs, or are we using these biologic agents as simply adjunct to what we're currently doing in surgery. And so to understand that, you need to understand the rules of the game. So biologics generally will fall under this Section 361, which is considered low risk, as long as it qualifies the following. It is minimally manipulated, meaning that you can probably use tissue in a centrifuge, but they have problems with you doing anything else to manipulate the tissue. It needs to be homologous use, meaning it has to be used for something that the tissue is already familiar with. So you can take bone marrow into a joint, but they have, whether you take fat into a joint, maybe a little bit more of a gray area. They don't want you combining the biologics with other drugs or devices. It has to be autologous use, and it has to be a point of care, meaning that you can't use a lab and you can't keep it overnight, incubate it. It needs to be basically same-day service. So let's jump into the big three of biologics. We'll start with mesenchymal stem cells. And these mesenchymal stem cells come from two sources in the human body. One is in the adult human body, I should say. One is bone marrow, the other is adipose tissue. So in bone marrow, when we do a microfracture, we're basically trying to recruit these progenitor cells. And we can also obtain mesenchymal stem cells from the bone by something called BMAC, or bone marrow aspirate concentration. Mesenchymal stem cells are also found in high concentrations in fat. We can get those from procedures such as liposuction, and there's some studies that have looked at using the fat pad in the knee as a source of mesenchymal stem cells. when you ask a cell biologist what an MSC is, he has a very strict definition. In other words, these are cells that express certain membrane markers and don't express others. But we have to be very careful when we look at the studies to figure out what an MSC really is, and so the definition of an MSC is something that you need to look at very carefully, because not all the studies actually include cell markers. This is just something for you to keep in mind as we go through this. So what do we know about mesenchymal stem cells? Where they're cultured in monolayer, they're plastically adherent. They can differentiate into bone, fat, and cartilage. What we don't know is exactly how we can induce a stem cell to grow into the lineage of any one of those three things, and exactly whether the desired lineage is induced before you introduce the cell to the pathology or while it's being introduced into the pathology. How do these work? Well, we like to think that mesenchymal stem cells magically just differentiate into whatever tissue we want them to become, but the truth is that occurs actually in very few of the times that we use MSCs. More often than not, it's what we call a paracrine effect, or an indirect effect, where the cells can stimulate angiogenesis, they can limit inflammation, and they can help recruit other progenitor cells. So let's get to the nitty-gritty here. What are the clinical applications? The two things that you want to know when you're evaluating the biology for your patients is, number one, is it safe? And number two, does it work? And when you say does it work, you really want to know what the randomized controlled trials, the level 1 and level 2 studies are saying about these applications. So, as it relates to mesenchymal stem cells, there's plenty of data out there that has looked at the use and whether or not it's safe. Chris Centino did a multi-center study using bone marrow-derived stem cells. Mark Berman, Elliot Landard recently published a large study looking at almost 1,800 patients with adipose-derived stem cells, and the quick answer is yes. In terms of safety, mesenchymal stem cells, when they're adult-derived, do appear to be safe. Well, do they work? Chawla down at Methodist Hospital in Houston last year published a study looking at all of the bone marrow aspirate. It was a systemic review of the bone marrow aspirate studies that were currently out, 11 studies in total, 3 for osteoarthritis and 8 for focal chondral injury. All of the studies reported good and excellent outcomes, but there really was marginal quality in these studies. So we really are just now getting to the point where we're seeing some data on bone marrow aspirate. Up to this point, it's been a bit of a black box. Now, this year, about 2 months ago, Shapiro at Jacksonville, Florida, published a study for mild to moderate knee arthritis. It was a prospective, well-done, single-blinded, placebo-controlled study, level 2 study, 25 patients with knee pain, again, diagnosed with x-rays. Half of those patients got bone marrow aspirate, which was spun down to 6 cc's of cells, and the other half got saline injection, and they found similar relief of pain in both the bone marrow aspirate and the saline. So this is where we are today. At this point, we do not have evidence that bone marrow aspirate is actually going to be different than placebo for mild to moderate knee arthritis. Well, what do we know it works for? Hernigau in France did a study that is worth mentioning. It was a relatively large study, and it had a 10-year follow-up. And he looked at augmenting rotator cuff repair with mesenchymal stem cells. So he had 90 patients. 45 of the repairs were done with a bone marrow aspirate injection following the procedure, and 45 of them were done with no bone marrow aspirate. Again, 10-year follow-up with either MRI or ultrasound. At 6 months, they had a 100% healing rate in the rotator cuff group that had received bone marrow aspirate versus about 2/3 that had healed in the control group. At 10 years, these results held up at 87% in the bone marrow aspirate group that were healed, and 44% that had not healed. So it does appear that at this time, in 2017, bone marrow aspirate, there is evidence to suggest that it will help with rotator cuff repair. Let's shift gears. How about PRP? What do we know about PRP? There's a lot more data on PRP. Why is that? We've been doing it for a much longer time. So we're starting to get some real data on PRP. By definition, platelet-rich plasma is simply a sample of autologous blood with any platelet concentration above baseline. It contains 3 things. It contains plasma, platelets, and leukocytes to a varying degree. How does it work? Well, none of the cells are actually differentiating. It's all through an indirect effect. Again, growth factors can be chemoattractants. It can stimulate cell proliferation. And what else does PRP contain? Well, interestingly, the PRP that contains white cells actually contains a higher level of inflammatory cytokines. So we have tumor necrosis factor alpha, interleukin-1. These are known to increase tissue damage. So when you look at the difference in the PRP preps, one to the other, they're generally categorized as either those that contain more white blood cells, or what we call leukocyte-rich PRP preparations, or those that contain less white blood cells, the leukocyte-poor PRP concoctions. And as you'll see in the data that I'll present to you, it seems that the leukocyte-poor PRP prep is better for osteoarthritis in the joints, and the leukocyte-rich is likely better for tendinopathies. And it's probably because of these inflammatory cytokines that can have a negative effect on the knee. So let's talk about the same thing. Clinical applications, this is for PRP. Is it safe and does it work? Pat Smith published an excellent study last year, level 1 study looking at PRP versus saline, 12-month follow-up. There were no adverse effects of the PRP group, so yes, it is safe. Well, does it work? Chris Mehow down at Baylor looked at the efficacy of intra-articular PRP for knee arthritis, did a systemic review, only looking at level 1 studies. There were 6 articles, a total of 739 patients, and they did show that PRP injections result in significant clinical improvements up to 1 year after injection. How about for advanced osteoarthritis? The group in Barcelona published a study this year looking at a prospective randomized double-blinded study of 75 patients with Kellgren-Lawrence grades 3 or 4, so that's severe arthritis. They were randomized to either a single leukocyte-poor PRP injection or a single cortisone intra-articular injection, and they looked at pain scores, functional outcomes, and health surveys at 1, 3, and 6 months. All variables improved in both groups, but the magnitude of improvement tended towards greater magnitude in the PRP group. So they concluded that for late-stage osteoarthritis, a single leukocyte-poor PRP injection has similar results to a single shot of corticosteroid. What about comparing PRP to hyaluronic acid, something that we all are familiar with? Well, Brian Cole did a level 1 study last year comparing the difference between 3 consecutive HA injections done 1 week apart and 3 consecutive PRP injections done in similar intervals, and found that there were higher functional scores and lower pain scores at both 24 weeks and 52 weeks in the PRP cohort. Patients that had milder arthritis and lower BMI did better in both categories, which was not surprising. And they also found a trend towards a decrease in 2 pro-inflammatory cytokines in the PRP cohort. So it does appear that there is evidence that PRP is better than saline and likely better than HA when done in the same frequency. What about for hip osteoarthritis? Study out of Italy last year looking at ultrasound-guided injection of 3 weekly injections of PRP versus 3 weekly injections of HA separately and in combination for hip osteoarthritis. Again, they looked at pain scores, functional outcome scores, the Harris Hip score at 2, 6, and 12 months. In all 3 groups, the PRP alone group had lower pain scores at follow-up times, and at least for the first 2 follow-up timelines, which were at 2 and 6 months, the PRP alone group had better functional scores. They found no adverse effects in any of the 3 groups, and they concluded that an intra-articular PRP injection offers significant clinical improvement in patients with hip osteoarthritis. Okay, what about PRP for tendinopathy? Well, this is clearly the sweet spot for PRP, and this is kind of where we started. We have some good data now looking at the use of PRP with all the studies that have looked at tendinopathy, which was 18 studies, over 1,000 participants, and they found that most significant outcomes in the PRP group was seen in those treated with the leukocyte-rich PRP preparations. Remember, that's the PRP preparations that includes additional, a higher concentration of white cells. And they recommended using a peppering technique where you can move the needle to several different spots, intratendinous injections, and ultrasound guidance to allow you to localize the position of the needle. Jason Dragoo did an excellent study a few years back looking at PRP for patellar tendinopathy specifically, another double-blinded study with 23 patients that either underwent leukocyte-rich PRP injections or dry needling. And at 12 weeks, the PRP group had no failures and had improved significantly more than the dry needling group. Interestingly, the results dissipated over time, and the reason that's interesting is because Alan Mishra at Stanford did a similar study with lateral epicondylitis and found no difference at 12 weeks, but that over time, the leukocyte-rich PRP group had better improvement at 24 weeks. So it seems like with patellar tendons, we got early onset of improvement, which faded. With lateral epicondylitis, there's evidence that it helps early, or excuse me, that it doesn't make a difference until you get out beyond the first 4 months. The last of the biologics I'll briefly mention, because there's really not a lot of data here, but it's the human amniotic-derived products. These are becoming more and more popular, as I'm sure you've had various reps come to your office to tell you that this is the latest and greatest. Amnion is simply, in terms of its preparation, the amnion is separated from the maternal chorion. The amnion is made up of 3 layers: the epithelial cells, which are basically the active producing cells, basement membrane, and an avascular mesenchymal tissue. In order for this to be approved, or at least cleared through the FDA through the Section 361, it has to be dehydrated or cryopreserved. It is almost always decellularized. It can either be through radiation or sterile filtration, so you're not getting any live cells with these preparations. So don't let them tell you otherwise, but it's important to understand that you're not getting stem cells when you use human amnion. What can we use it for? Well, the 2 good studies I would refer you to that have come out in the last 12 months that look specifically at the uses and the potential benefits of the human amniotic membrane products. But what we know now is that it is probably safe, and in terms of what it does, it provides a matrix for cell migration. It can enhance wound healing, which at this time is the only approved label for this tissue. It can reduce inflammation. It has some antibacterial properties, and it can reduce pain at the application site. So any use other than wound covering at this time in this country is considered an off-label use. And we don't have any evidence right now that this actually works, but there are currently 6 human studies reported. Works in terms of sports medicine, that is. 5 of the 6 applications are for foot and ankle pathology. These are all diabetic ulcers and diabetic wounds, as you can imagine. And at this time, there's no, as I mentioned, no randomized controlled trials that are available. So in conclusion, the research in biologics for sports medicine is starting to bear some fruit. We're starting to get some real data that I think we can use when we counsel our patients about the role of this. It's clear that PRP in osteoarthritis and tendinopathies is becoming a more important part of treatment. There's still significant knowledge gaps which exist with respect to the mesenchymal stem cells. And amniotic cells or tissue, in terms of the studies, they're really still kind of on the starting block. We haven't gotten very far with these, so further studies are necessary. So I think we're a little bit ahead of this cartoon, which says the his physician is telling him it's nothing a few stem cells and another 75 years of research can't fix. We're probably a little bit ahead of that, but for the most part, I think we're where we are today. Thank you very much.